Alrighty, let's get started with grand rounds. Okay, so first up to the podium, we have Dr. Salwa Mikhail, who earned her undergrad degree from WashU before going to St. Louis University School of Medicine for her MD. She came back here to WashU for her internal medicine training, where she's been actively involved in the WU-TIP pathway with a particular interest in feedback. Now in her third year of residency, she is planning a career as an academic hospitalist. Please join me in welcoming Dr. Salwa Mikhail to the podium.
Thanks, Emma, for that great introduction. I'm super excited to be talking at Grand Rounds today. This is just a disclosure slide saying that Ashton and I do not have any disclosures. So today I'm planning to talk about a project that I'm a part of as a member of the teaching physician pathway that I've found to be super interesting because of the way that it hopes to better medical education by improving the feedback that medical students receive in a way that specifically incorporates AI. So the name of the talk today is Feedback on Feedback, Leveraging ChatGPT to Enhance Medical Trainee Assessments. The objectives for the talk today are to describe the use of AI in medical education, highlight the application of AI specifically in feedback, and then to outline the research project that we're a part of. So I'll talk a little bit about the ChatGPT application of the EFECT tool, our needs assessment, and then also what to look out for generally this year. I wanted to start off by discussing more broadly the topic of AI in medical education. I think we've all noticed how AI can be helpful in our own medical training with the advent and use of open evidence, an AI-powered platform that synthesizes and organizes information, helps us answer clinical questions in our own day-to-day. Looking through the literature, this study provided some interesting background. It's a systematic review of 278 publications from mostly North American and European regions, and it describes different hot topics commonly being discussed in articles. So it talks a little bit about using AI for recruitment, admissions, and selection, teaching about AI or AI-augmented instruction, AI in the assessment of clinical, surgical, procedural skills, narrative text analysis, and then AI to also teach or assess clinical reasoning. There were articles that commented more generally on the knowledge and the attitudes about AI that people have, and also how large language models perform on medical exams. So as you can see, it's a really broad topic with a lot of different applications. And then it's pretty neat to just read through all the different examples that are given in the article about how AI is being used in med ed. So here are just a few that I thought I would share that were interesting. There's an AI chatbot that's being used during recruitment to host virtual Q&A sessions. AI is training learners to identify findings in radiology on imaging, training learners in derm to identify certain rashes or skin lesions, and then also how to acquire optimal echo views. There are AI-powered video analytics that are monitoring and assessing users' performance in minimally invasive surgery. And then if you remember our OSCE days, there's now virtual OSCEs, virtual patient simulators, and then automated grading of OSCEs. The article discussed a little bit about intelligent tutoring systems as well, and then also how students and educators are using AI to generate multiple choice questions and come up with study resources. The study also discusses how AI is being used to analyze narrative assessments that attendings give residents and clerkship students in order to inform clinical competency committees, generate ratings of faculty feedback, identify learners at risk, and then also identify biases within narrative assessments. And so I would say our project focuses specifically on using AI to amplify feedback, and so it falls into this category. So I want to shift gears and talk a little bit about the research project that we are a part of. So I want to start out by asking the crowd, just a general show of hands, who has received unhelpful feedback or given potentially unhelpful feedback at some point in their medical training? Okay. If you look around, you can see most people have their hands raised. So I wanted to show a personal example. This is my new innovations, and this is some of the responses I've gotten to in which areas should the resident focus for growth or improvement. So I've been told to focus on reading, experience, and NA. So to me, I think this is a very relatable issue. A little bit more about generally how we were doing. Internal medicine clerkship students rated the quality of formative feedback as around 3.29 on a scale of 1 to 4, with 1 being very dissatisfied and 4 being very satisfied during the year 2022. And then just looking through the literature, you can see that national trends show mediocre verbal and written feedback from assessors. So this is an area that we can improve on. So the goals of the project take this into mind. Our goals are to identify whether delivering feedback to assessors iteratively on their written narrative assessments improves the quality of narrative assessments in the IM clerkship. Talking a little bit about how we're doing this. Some of this is a part of Sarah Coates, our Chief Residence Research Project, and I'll give a shout out to her later in the slides as well. So some of this has been done and some of this is still ongoing. We identified a tool used to measure the quality of narrative assessments and then used AI application of this tool, the effect tool, which we selected. And then we're planning to deliver effect scores with suggestions for improvement to assessors and then track whether the effect scores improve over time. And then to talk a little bit about the tool selection process, there have been several instruments that have been designed to score the quality of written narrative comments, including NEQI, QUAL, and the EFECT. You can see they all have like acronyms and what they stand for. EFECT stands for the Evaluation of Feedback Captured tool. And what our team did is we applied these tools to narrative comments, and then we were able to calculate inter-rater reliability, and then also just generally reflected on the relevance and the ease of use of the tools, and ultimately selected the effect tool based on that. So I wanted to show the effect tool itself. I think looking through this and what it takes into account was helpful for me when I'm trying to write feedback for medical students that I work with. So this tool generally gives a score from 0 to 5, with a higher score indicating higher quality of feedback. And so you can see here, it'll give a point for identifying what the learner did, so whether or not they, for example, diagnosed patient or performed a history and physical. It'll give a point for providing some context, so saying when, who, or where. So there's a cue about the type of patient or the setting that the encounter took place in. It'll give a point for identifying generally how the learner did, identifying what was done well or needs improvement, so being specific about the task. And then it'll also give a point for how was it done well or how it can be improved. And the idea there is if something was positive, the learner should know exactly how to replicate that. And if there's an area for improvement, they should know exactly what they need to do to get better next time. I did want to show some of the needs assessment data that we gathered that supported our project goal as well. So we sent out surveys via emails to attendings and then also provided a link to residents' outpatient didactic sessions. And we were able to get a total of 66 responses. So in response to the question, how likely are you to incorporate feedback on your written narrative assessments? As you can see, for the most part, people were likely or very likely to do so. And then this was just asking how often they would like to receive feedback on written assessments. Around 1 to 3 months was generally the answer there. And then how would you like to receive feedback on your written assessments? For the most part, people responded via email. So this generally helped us figure out how to go about distributing our feedback and also supported our project goal. I want to talk now about how we actually applied ChatGPT. So we designed a prompt for WashU ChatGPT to apply the effect tool, determine the score, and then suggest an area for improvement. And this involved a research team member, Sarah, going through with ChatGPT and feeding the effect tool in and asking ChatGPT to apply it to narrative comments. And then we would go back and forth and kind of tweak the responses that we were getting until it was consistently giving a desired result. And then she shared what she had entered into ChatGPT with other members of the research team, and we were able to put that and train our own WashU ChatGPT using that information. And so after we were able to train our ChatGPT that way, I took a screenshot here of what I was able to enter into my own. And so I typed in, please score the following comment. The student efficiently took a history and performed a physical exam on a patient with heart failure. Keep reading. And now I'm going to show you what the output was after that. So it spits out like a total score. It'll tell you 3 out of 5, and then it'll explain why it gave that score. So it here says it gave a point for naming what the learner did, a point was provided for context, and a point was provided for what was done well or needs improvement. And then you can see here that no points were provided for how the learner did or how it was done well. And then underneath, it'll be a little bit more specific about suggestions to improve narrative comments. So here it says, you could better have explained how the learner demonstrated certain attributes or offer clear and actionable suggestions. And then underneath, it has more specific ways that that could have been done. And then, again, some validity evidence for the I wanted to share some validity evidence for the AI application of the effect tool. And so this is a part of Sarah's research project, so I wanted to shout out for her. And then also Dr. Montanet for performing the statistical analysis for this. But basically what we did is we compared manual and AI-generated scores for each comment, and we were able to determine a subset of low, medium, and highly scored comments on the effect tool, and then also determined a proficiency cutoff point based on the AI numerical scores. And then as you can see in the table below, we were able to calculate sensitivity based on that by seeing if the AI and manual both met threshold. And so our sensitivity was about 84 to 99%. We also used a scoring system to help calculate accuracy. And for that, we went through and gave a point if the total AI effect score matched our manual score, if the area of strengths matched, if the area for improvement matched, if there was a reasonable suggestion for area for improvement, if it focused on a skill or behavior, and then it did not reinforce inappropriate language. And so we were able to calculate accuracy that way, and we got around 79%. And then we also looked at time savings. So we looked at, on average, how much time was saved using ChatGPT versus when we manually scored the comments. And we got around 97 seconds. So you can see this does help a little bit with efficiency. And so the team is planning on using this ChatGPT prompt to generate feedback on written assessments throughout the year with the hope to distribute the feedback around monthly. And the hope is that providing this feedback will help assessors identify areas for improvement to hopefully give better feedback in the future. And we're planning to compare the effect scores over time to see if iterative feedback actually does improve quality. And this is just a screenshot of an email like template that you might expect to receive this year that will say, we scored your feedback and this is the score you got and some suggestions for improvement. So I just want to acknowledge other members of the research team, say thank you to Dr. Zicker, Dr. Kerrigan, Dr. Montanet, Sarah, and Alyssa Cooperstein, for WooTip for helping me, get involved in this project, Dr. Shashelsky for going through the presentation with me, as well as friends and family. They've heard me go through it a couple times, and then for everybody who took the survey as well. And these are generally my references, and then I'll open it up for any questions.
Thanks so much, Salwa. We'll open it up for questions. Edward.
Hey, great job, Salwa. Very interesting topic and great use of trying to use ChatGPT. One issue that I struggled with is when I give verbal feedback, I try to get as targeted and specific as possible, and I sit down to write it down, and I'm like, how do I translate the 5 to 10 minutes of what I spoke into a written form? So what are your thoughts on ways that we can improve? And then before that, even giving feedback in the first place is a challenge, as evidenced by the 20-30% people who were unlikely to even give, neutral or unlikely to give feedback. But what are your thoughts on improving ways that we can get, actually getting the written feedback down? Because I feel like that's a barrier. Just sitting down, we have 15,000 surveys to fill out. We're just trying to get through them all. Does that make sense?
Yeah, no, that's a great question. I think, the fact that you're giving good verbal feedback at all is wonderful. I think even some folks don't get that, so that's great. I think, something that's helpful is just trying to do the written feedback as close to the verbal feedback that was provided. I think that can be helpful. And then also for me, just having seen like the effect tool and other kind of tools that have been used to score comments, I kind of keep that in mind now when I try to write my own feedback, and it helps me kind of go through like what, you know, I generally should include for the students. But I think that that's like a great question, and it can be difficult and kind of an area for improvement. So, yeah, Dr. Schweitzer. Thanks.
Super interesting. I have a couple questions and comment. One is, it seems like before you start providing feedback, provide the effective response.
Mm-hmm.
Like, you know, just see, I took a screenshot and I'm going to use that, you know, so that I'm sure I'm covering that. My question is, you know, generative AI is generative, and you trained it to a point where you felt it was doing a good job. But is it going to keep learning, do you think, or it's done learning?
I think, I would think that if, you know, we put in comments and it spits out a score, I think that it would probably learn if we would put back in like, no, I didn't like this, or do this next time. I'm not sure if it would necessarily learn just from like the process of scoring. So I would think it would need like some tweaking in order to kind of change, is my understanding. Sarah's the one that actually went through and like typed in and trained AI, but that's my understanding of how the process went.
And my final question is, what about using the effect tool to put prompts into, I mean, because we get these general, you know, write what you think kind of things, but why don't you prompt us on, you know, what is something the trainee did well, what is something you're, you know, so that you're actually prompting us to give them.
Mm-hmm. Yeah, I think that's a great point.
Can I just add something about the AI?
Yeah, yeah.
So AI only gets smarter when it goes through a new iteration, when it gets updated, because that's when all the new data gets put into AI. When you're talking to AI and you're getting like more specific responses from it, you're actually only honing in on its context. So it's still using probability with whatever brain information it has. It only gets smarter as it gets updated.
Thanks, Dr. Zicker. Sure. Yeah.
Hey, do you think that some of these other AI generative models like Claude or some of the ones that are a little bit better at narratives in general or sort of like illustrative things, do you think it would be better than the ChatGPT version that we use? Do you guys ever experiment with that?
Truthfully, I'm not super familiar with that. You said it's called Claude?
Yeah, like
Okay.
Google's big AI one for doing like narrative
Okay.
and things like that.
Yeah, I don't have too much experience with that.
So my experience is that all the other AI platforms are better than the WashU one, but WashU is it's not Interpa compatible. And since we're dealing with student assessment data, we're limited.
And that's GPT 3.5 for the WashU
I
one?
believe so.
Okay.
But that's like probably for the better. Large language models learn from all the internet, and there's less protections on the internet now to keep data accurate and correct. So even if the ChatGPT doesn't use as much, like for its model, it's probably still better for these things.
Thanks, everyone, for your questions. I appreciate it. Thanks.
Thanks so much, Salwa. All right, last but not least, we got Dr. Ashton Naumann. He completed his undergrad here at WashU, where he majored in biomedical engineering. He then went on to earn his MD at University of Florida College of Medicine before coming back to WashU for his internal medicine residency. He is currently a member of the teaching pathway as well, reflecting his dedication to medical education alongside clinical care. Now in his PGY3 year, he is preparing a career as an academic hospitalist. Let us welcome Dr. Ashton Naumann to the podium.
Give me a second to set everything up here. Okay. Can everyone hear me okay? Cool. Okay. So big picture, I'm going to be talking about quality improvement and it's going to be more of a conceptual talk. And my goal for all of you is basically just to be better QI stewards coming up with system solutions through your daily clinical practice. So just for starters, thank you for introducing me. I didn't know you were going to do that, so I threw in a slide myself. I was a biomedical engineer at WashU as an undergrad. Then I went to the Florida Gators UF for medical school. And professionally, here I'm part of the teaching physicians pathway, and I'm also part of the new health systems leadership pathway. And my broader clinical interests are becoming an academic teaching hospitalist. And another thing I kind of do in my free time as a resident is I'm an Epic physician builder, which basically means, when we interact with Epic for our clinical visits, that's kind of like the user front-facing Epic. There's a lot of settings, alerts, and thought that goes behind what you see as an end user. And Epic Physician Builders are one of the many people that kind of contribute to what that environment looks like. And the hope is the physician builders bring their clinical background to make tools that make sense and work for the patient and the physician's best interest, to kind of guide the IT technical skills of Epic, broadly speaking. And then long-term, I'd like to kind of combine all those things together to do QI leadership work. And just two pictures here. The top one is me and my partner Shay. We're at Banff National Park. This is Big Beehive, and this is Grand Prismatic Spring at Yellowstone. My big interests outside of medicine are soccer and getting outside, so national parks are a great way to do that. Okay, so my goals for you guys today in terms of learning are: 1, describe examples of Mura in healthcare. You might not know what that is, and that's great. 2, recognizing daily clinical cues that suggest a system solution is needed. And then 3, just giving some general guidance on how to utilize language to kind of amplify your ideas for change making beyond your clinical work with patients. And the way we're going to do that is I'm going to talk about some basic QI foundations and definitions, maybe take you back to medical school. Then I'm going to use some basic cues that I see over and over again that tell me maybe a system solution would be beneficial for the problem that I'm facing. And I'm going to use some Epic project examples that I've done over the past year to illustrate what that can look like. And then lastly, I'll just give some examples on change making broadly. Okay, so first section, QI foundations. So got to start off with a case. So Dr. Beargater is an otherwise healthy physician who loves talking with patients as well as thinking through diagnoses to treat and improve their quality of life. Lately, it feels like there's less and less time to think, leading them to feel unfulfilled and disconnected from their work. Scanning through emails, they include: reminder, appropriate billing for timing and complexity. 2, you have been assigned a mandatory learning on SABA, sepsis, following record high misses on the unit this month. And 3, a weekly news letter that says, please read. Dr. Beargater takes this in, reflects, and says, I often miss the complexity modifier on full clinic days, despite my best efforts, because I'm busy. And thankfully, last time I was on firm, we didn't miss any cases of sepsis, and our patients did pretty well. Ultimately, they open up the sepsis module, they hit play, delete the emails, and then they go ahead to open Epic to pre-chart for their clinic or their morning hospital pre-rounds on a second screen, separate from the module. Oh, and then there's an alert for that. And I think just between us, I'm not going to be the primary physician here, so I'm going to defer this. Okay. Okay. And again, but it stays in this room. I'm not the one who's going to address the sleep apnea right now. We're going to try to get through this talk. Okay. So starting with QI foundations, the kind of modern day QI starts at actually like a car factory, the Toyota car plant. And they had this philosophy called the 3 M's. And it's a Japanese car company, so these words are rooted in Japan. And those words are Mura, and Muri. And they each stand for a different like fundamental pillar of QI and things we can address to make our care for patients better. But taking a step back, for quality improvement, broadly speaking, My favorite definition is just doing the right thing with the right people at the right place, the right time, consistently. I think that's the simplest way to describe what we're shooting for here. So to kind of give you the definitions of those words, Muda refers to waste, which I'll talk more about in a second. But a great example of this is if you went to a restaurant and you ordered like the mac and cheese, and the chef makes the mac and cheese and they burn it. And then you say, oh, I don't want the burnt mac and cheese, so can you make another one? And the chef says, of course, and then the waiter brings it out, and you have your mac and cheese, you enjoy it, it's cheesy, and then the bill comes out, and the bill charges you for 2 mac and cheeses. You'd be really upset, right? Now, in the medical context or in the hospital system, we tend to pay the patient or the physician team, we pay the bill for that burnt mac and cheese, the loss of improvement or the waste. So that's kind of that first concept. The second concept is mura, which is referring to inconsistency. So this is just not doing the right thing or not doing it in the same way every time. So if a patient has community-acquired pneumonia, there are certain antibiotics that they should get in a timely fashion. Maybe some patients who had pneumonia we miss, they get no antibiotics, and maybe some get vancomycin for 7 days. So that's an example of inconsistency in waste. And then lastly, which I think is one of the things that drives my interest in QI is MURI, which is the idea of overload. Toyota referred to overload in the sense of their machines doing too much work too fast and kind of burning out the resources that they had, leading to like excess wear and tear. But I think in the medical setting in the hospital, we can think of MURI more as what our cognitive burden is and our cognitive resources are. Because if there's a lot of waste and there's a lot of inconsistency, that generates a lot of extra work. And ultimately, that bill is paid by us as the clinicians. That may be extra calls, it may be extra chart digging, it may be longer hours. And so by not being diligent in the other two areas, we ultimately are overloaded, and that obviously has a lot of impacts in terms of burnout, learned helplessness, and for those reasons, that's kind of what motivates my interest in QI. Okay, so kind of diving into the muda or the waste a little bit more, specifically in medicine. There are these like 7 categories that they fall into, so I'll just describe brief examples so you can recognize it on the day-to-day. The first one is the concept of overproduction. We don't see this as much, especially as clinicians, because we don't handle the ordering of our supplies, but this would be like ordering 9 million bags of vancomycin and only needing 500 and they all expire. Of course, when we order those bags, they have to be transported. The more you order, the more that needs transport. And then inventory refers to the storage of these items. And the longer they sit there, that has storage costs, upkeep costs, and then ultimately more waste. And then now we get into more the areas that we think about as clinicians, and that's waiting. So I think of this mostly as like the time people sit in the ER, either to be evaluated or the time they sit to be brought up to medicine firm and be in the best area for the care that they need. Motion refers to the idea of basically a physician having to move more than they need to get the care done that they need. So geolocalization is a great way for primary teams to stay in a very small space, to bop between all the rooms, and it reduces their waste in that way. And then I think the last two are maybe the most we feel on a day-to-day basis as clinicians, and that's over-props processing. That can look like many things, but one example would be like the first-year medical student length of a note and detail for every clinical patient that you see during your day. The over-processed information is nice, but maybe not what we needed to get the job done. And then lastly, all of these things boiled into defects. That's adverse events, that's misses, sentinel events, et cetera. Bad outcomes for patients, and at the worst, mortality for patients. Cool. So those are all different, what waste can look like, but now let's transition gears to how to find solutions, what solutions can look like. So one of the QI-based ways to discover solutions is to go on what's called a Gemba walk. And I added walk and talk to kind of ground yourself in what the problem looks like. The reason this is important is you can't really make wise system changes from a tower. You have to see the reality of the day-to-day where the decisions are being made, where the waste is happening. And so what that looks like for Toyota was just walking the actual factory floors, seeing the cars be made, talking to the mechanics who are working on the cars, and asking them, what are the problems that you're facing? What are the solutions to these problems? Or what do you think about my proposed solution? Taking that feedback and then delivering the system solution. And by doing that, you can discover rate-limiting steps, bottlenecks. You form great relationships with the people who are ultimately the experts in the field, not you who's making the system change. And then collaborating, making sure your change that you're doing is collaborative. And you may ask why this is here. I would say that in The Wizard of Oz, when Dorothy took her walk to Oz, that could have been a Gemba walk in a sense. She had to walk the whole yellow brick road, go into the Emerald City, and meet Oz to realize he wasn't all he was meant to be. And on the way, she met some great process experts with the Scarecrow, the Tin Man, and the Lion, who ultimately helped her, save the day, I guess. Okay, so we've recognized the problems, we've talked about the potential solutions, but now comes into implementing what those solutions actually should be, and what's the appropriate level of this intervention. So when I think about change in the QI setting, I think about individual change, and then I think about system change. And it's a gray area in between. But the individual is someone who's very adaptable, but as people, we are subject to the memory and motivation to make any change. And those things fade with time and turnover. So when we're at a teaching institution, we're particularly vulnerable to that because we're constantly turning out residents, fellows, and as well as the typical faculty turnover. And so for that reason, individual changes are not as robust. And that's why then you think about systems changes. System change tends to be slow, which I'll talk about a little bit later, but it can create the momentum and the environmental conditions that allow the individual to succeed. If you're an expert in your field, it's also a way for you to create a change that outlasts you when you retire ultimately, because the change, impact, and expertise that you brought and the change that you implemented will be here long after you leave. And those things minimize our error, and they alleviate the cognitive burden that we have to make in each individual decision to get through our day. And that ultimately frees clinicians to do what we were meant to do, which is diagnose, treat, and move on to the next patient. And so here on this side is called the hierarchy of intervention. This is kind of just putting that in a picture, which is saying as you move from individual interventions like education, like modules, reminder emails, pamphlets, and move up to things like automation, creating environments that have force functions that just encourage folks to make the right decision, the level of robustness of that intervention increases. A simple example of this is when you order certain referrals, there is information that is required of you before you can place the referral. That's an example of a force function to ensure that the receiving team has everything they need to make the decision they need to triage the patient. Okay, so that's the QI foundations. These two pictures are from the Tetons, which is probably my favorite national park. If you're a big hiker, this was a great hike. It's like Watchman's Outpost or something like that. You start from the ground, it's like 80 degrees out in the middle of the summer, and you end up in the mountains where there's snow. And there's this little Watchman cabin that's all wooden, dilapidated. And then on the left, if hiking's not so much your thing, but you like sweets and you like an easy ride for a good view, there is a gondola that takes you up to a ski lodge type thing, and they have waffles of every kind you can think of. And you can just enjoy your view and head back down on the gondola, no work. All right, moving on. Cues for system solutions. So this is kind of the meat of the talk here. So things that should cue you in for system solutions in your day-to-day clinical practice are, these 6 are just a few that I picked out as themes. The first one is recurrence or repetition. Second is dependence on memory and vigilance. Third is high impact. That's where I'm going to focus my talk just for time's sake, but a couple other ones to be aware of are when you see yourself or someone else doing workarounds just to get your basic job done, say, I'm not going to use X system. That's a problem that needs to be addressed. And then there's a certain degree of complexity that demands a system solution. So for example, we often deal with telemetry box shortages throughout barns, and that's very complicated because it's a clinical issue, it's also like a supply issue, and it's also a staffing issue. So those things require a little bit more help than maybe you can do as an individual or even like one department can tackle. And then similarly, lack of clear ownership. I can't really point at one group to say telemetry ordering is your responsibility, please take care of it. It's going to be a collaborative approach. Okay, so repetitive and recurrent. So what this sounds like is you'll hear a lot of, I wish there was a faster way to do this. This is pretty tedious. I just don't have enough time to do blank, or I feel overwhelmed. And it can often look like friendly email reminders to do X, Y, or Z that you've probably seen multiple times this year. What it looks like for us is charting common problems. We see a lot of patients for heart failure exacerbations in the hospital. We treat a lot of them quite similar, at least at the base level. And there's a standard set of questions that we have in our mind for the HPI, and as well as a standard set of interventions for our assessment and plan. It also looks like the lag time between when you make a decision for a patient and you've put them in their bucket to when they actually get the treatment they need, to when the cardiology team sees them, to when the diuresis actually happens. And now lastly, common adverse events, so recurrent events, things that just seem to not go away for you and your team or your department. So in the hospital, that's like falls, pressure ulcers, hospital-acquired infections, things that just are always going to be there that need a more robust and multifactorial approach. And that's how I feel when I'm charting on a day-to-day basis on firm. Maybe you guys feel the same way. Okay, so here's my first project example regarding repetition and recurrent clinical cues. What this is it was requested by the endocrinology department, Dr. Natalia Gennari. She's also a physician builder. She requested this, and I built it with our team. She was saying, in the diabetes clinic, we handle a lot of diabetes in endocrinology. And, it sure would be nice if we had a compact way within our note that we could save reviewing medication lists and just see what the active anti-hyperglycemic agents are. And so what she requested was simple. Can I just get a list of anti-hyperglycemic agents that I can put in a note? So what we did is we made a system smart link available to all outpatient providers, .anti-hyperglycemics. As you can see here, it's an insertable smart link into her note, and it highlights all the pertinent information that would otherwise be in the medication list. This is a really quick, low-hanging fruit system change to do, but for the endocrinology department on a day-to-day basis, it has you can imagine the cumulative impact of not having to scroll over, go to the medication list, scroll through all of them, maybe you miss some. This will alleviate some cognitive burden for them by just having the pertinent information just in time, right where it needs to be, and take that step out. All right. So in that spirit, this is more into the practical things that I'd like to offer as we're going through these problems. I'm talking a lot about system solutions, but what can you do for your own system of clinical approach to address repetitive things that you do or recurrent problems that you experience? For you, that looks like utilizing Epic Smart Tools. The way to access that and explore that space is go in the hamburger in the upper left corner of your screen, click it, and find My Smart Phrases, and that'll open the vast world of smart tools for you. This can look like phrases. So I'm seeing a patient for heart failure. I always ask about chest pain, dyspnea, syncope, things like that. I can make a dot phrase that has all of those in there, and I just can hit enter whether they're there or not, instead of typing, this patient does not have dyspnea, this patient does not have orthopnea. and you can significantly reduce the time that it takes to conduct the clinical note from your visit. This can also look like order sets. I order telemetry, diuretics, electrolytes, BID for my heart failure exacerbations. You can have a standard order set for heart failure. All these can be programmed to happen at 2100, to be taken at night, all together when the nightly labs are done, instead of having to individually click all those into the orders every single time. Other things that are proven to reduce your total charting time for repetitive and recurrent issues are M-modal dictation. I put this in there in terms of how to set that up for yourself. And something that is happening in some of our BJC outpatient clinics is ambient AI note generation. I won't go too big into this, but essentially what it is it's a listening device that listens to the entire visit, compiles a note, like a assessment and plan. You review it, and then you sign the note. That's being beta tested in some of our outpatient clinics now. Cool. Next one. Dependence on memory or vigilance. What this sounds like. Be careful when you remember to, what consult service is on spine on Wednesday? What about addiction? What it looks like. Steep institutional learning curves for our particularly residents. How do I get this done? How do I get that done? I have to ask my attending, someone who's been here longer, versus it being evident in the environment already, and I naturally find my answers because the workflow is developed in an intuitive way. Ultimately, all of this generates a lot of waste in terms of motion. I might call 3 different pulmonology services before I find the pulmonary hypertension attending. Or I might put in 6 different referrals to accomplish the right physical therapy order. So this brings me to the second project we did. This was done as a hallway project in our primary care medicine clinic. We, as second years, do a QI project as second years. And there's about 8 of us, and we take a clinical problem that we see and try to find some solution. So what we chose to drill down on is we have a PAP clinic where we see patients for their routine cervical cancer screening. What we were seeing there is there was a lot of inappropriate appointments for patients who don't qualify for PAPs for different exclusion criteria. We have like a weight cutoff based on our equipment limitations. There's obviously you need a cervix for cervical cancer screening. And lastly, like an abnormal history would indicate they need to go to gynecology. And what was happening is a lot of patients who needed to go to gynecology were being triaged to our primary care medicine clinic, ultimately leading to waste for the patient, but also our learners not getting the pap smear repetitions that we would like them to have. And so what we did is we worked on a new referral to organize the PAP clinic referrals. Before, what you did was in your wrap-up, you would type up in free text, hey, please schedule this patient for PAP clinic. And you were expected to memorize these restrictions, and if you forget, that patient gets called, they get scheduled, and the resident and attending find out when they come into clinic, and you have to cancel. So all we did is put those requirements right into the referral and tell them to go to OBGYN if they don't meet those requirements. This just started in terms of being rolled out live on Epic, so we don't have any data quite yet. But you can imagine intuitively if we present residents with the information of what is an appropriate referral right in front of their face, it's a little bit better than expecting them to memorize during a busy clinic day. Okay, last piece here for the things to look out for clinical cues. High impact. This can look like volume, it can look like dollar, or it can look like high-risk situations. What it looks like for us, primary care, we see a lot of patients, which there's power in that because small changes to our system will impact a lot of patients. Alternatively, transplant is a very high dollar reimbursement for the hospital, so these are beneficial for a system solution just because the reward is high for any tweaks in quality improvement. And lastly, ICU care is very high risk, for example, so changes to those protocols, making that more intuitive, has a lot of impact in terms of patient outcome and mortality. And then overall, just an aside for why you should care about QI, when we ultimately get reimbursed for all the work that we do here, certain insurance companies reimburse the hospital based on what's called a DRG, or a diagnosis-related group. What this means is if I come in for a CABG, there's a set dollar amount that the hospital receives for everything related to that CABG care. The clinician cost, the room stay, and all the supplies. And now if we are extremely efficient, that's great for the hospital. We basically net the benefit, net the profit, and that can be distributed to all the other things we need money for, especially now. But if we're extremely inefficient, we have a lot of waste, we can actually essentially lose money on the care that we provide. And that's becoming more and more common as insurance companies are starting to reward quality, and honestly, as they should. Okay, so this is my biggest project, and it's kind of my baby, and it should be on the horizon here quite soon. This is an outpatient project, so I'll just briefly explain for inpatient folks. For Medicare visits, there is a G2211 modifier code, and essentially it rewards providers for providing longitudinal care to their patients. And that reimbursement is, depending on what complexity of visit you are billing, it's in the low double digits in terms of what it adds to the visit. So the current workflow is physicians are expected to recognize that this is a Medicare encounter, consider if this is a qualifying visit, and then add the charge as we're going through the billing. I can speak for the resident clinic and say that we missed this a lot, or I missed this a lot until I became obsessed with it. And there are some back-end things with billing in terms of addressing this, but a lot of them go missed, unreimbursed, and it's a missed opportunity for care we're already providing. So I thought, based on the requirements of this Medicare modifier, they're all yes/no questions that by the end of our visit are already in the chart. You've already done the hard work. So why make you remember? Why don't we just automate it? Why don't we just put something in the background that does that thinking for you? Because it's, unlike the complexity, a fairly straightforward question. Don't get lost in this, but this is just like pulling back the curtain on what it looks like in the backside, those levers that we can address as builders behind the scenes. All this does is go through and ask, is this an appropriate visit for the Medicare modifier to be added? Making this took me like a couple hours to think through what was an appropriate build. I've been working on this for about 6 months, and we're almost in the final testing and approval phase. I'm hoping in the next month or two. So this has a huge impact. It's going to be across BJC East, initially for all primary care settings. So, system solution. So that's it for the system solutions. This is an alligator. It's 15 feet long or so, and this is like a river fish something that struck me. I'm a Minnesotan by trade and youth, but something that struck me about Florida in particular was how comfortable people are with alligators. There would be people who sit on benches not more than here to there from the alligator, and they'll bring Publix is like the grocery store down there. They'll bring chicken, just chicken thighs, and they'll just say, here you go, and they'll just feed them like you're feeding pigeons with breadcrumbs in Central Park. Yeah, so anyways, glad to be here. Last piece here to wrap up, change language. When you recognize that there's a system solution for a clinical problem you're facing, there are just a couple brief tools that I've learned along the way that can really drive you to be successful when escalating to clinical leadership that can maybe help you. Be data-driven and concrete. Or another way to say this is lead with facts, not feelings. But do share the feelings too. Identify the problem, who it affects, and what the negative impact is that you're seeing. If you can come up with a solution or a direction for that problem, it's way more likely that you've already created momentum for a solution to happen. I'll say that in general, the high volume, high dollar, and high risk cases get accelerated and triaged by our technical department, as they should. But if you'd like a small change, maybe one that's more based on comfort to be accelerated, ownership is a great way to accelerate your idea. And just for time, I'll skip over this example of putting that all together. This is, again, more just for you. Here, if you're having issues with Epic, you're annoyed by something, the way it's built, that sleep apnea alert, you can follow this to submit a request for either something that's broken or something that's new. And then on the right here, if you have any ideas that would be big impact in terms of a system solution that an Epic intervention could be beneficial, since I'm wrapping up this last project, I'm looking for another big project to try to finish before the end of residency. So feel free to drop any ideas. No guarantees I'll do any of them, but just I'm in the brainstorming phase, and I'll contact you if we end up going that way. So just to wrap things up, Mura, and Muri, QI opportunities are everywhere in medicine. System solutions are resource intensive, but they're sustainable, and they can be a legacy of the expertise that you already have. And change-making language is data-driven. It identifies the problem and proposes first steps for a solution. And lastly, high volume, high dollar, high complexity, and high impact things are accelerated. But the more you can do yourself, the faster these things go. And I just want to thank all of you for having me here, and particularly Dr. Ren, Dr. Cao, Dr. Bauman, Dr. Chang, and Dr. Thomas, who've created a very unique environment for me to explore what has been a very atypical journey for a little hobbies outside of residency. Cool.
Thank you, Ashton. I think we have a couple minutes for any questions that people might have. Yes.
That was really terrific. I'm just going to put in a plug for the ICTS's JIT program, which is used to fund preliminary data for proposals, but also has a QI feature. We will provide $5,000 to you when you're in that question developing phase to get the data to put your proposal together. The hospital funds this. We never spend all our money. So send us some proposals for good QI projects. We're always looking for them.
Thank you.
Yes.
Physicians used to create a differential diagnosis, which I consider an analog problem. It takes a quarter of a lifetime to learn how to do that. One of the things I think these computers, the digital computers, are introducing the digital processing, which is not that process. It converges to an answer based on statistical evaluation, basically. Do you think these computers will eliminate the differential diagnosis?
Maybe not the maybe, or I should say, I think they could possibly substitute like a basic med student level shortness of breath differential, PE, pneumonia, et cetera. But what I think is very hard to do is the gestalt assessment of is this patient toxic, non-toxic? We got a consult on Palm Consults the other day for hemoptysis, and when you look at the patient, they look phenomenal. But if you look in the chart and their risk factors, it's a pretty nuanced clinical decision. So I think while the initial differential diagnosis may be readily available, I think the final decision in terms of the assessment, particularly the stability and wellness of the patient, are things that are just more refractory to AI in general or computer models.
Seeing the primary care patients are more and more not physicians, essentially, in the clinic, so they don't have any of that.
Yeah.
Thank you for the talk. I guess my question was going back to your pelvic smear project.
Yeah.
You're adding extra clicks in Epic
Yeah.
to clarify things.
Yeah.
How do you balance that with alert fatigue? And, I'm just thinking of the inpatient MRI screening form.
Yeah.
Every MRI, and I'm pretty sure I've never asked if my patient has had a cochlear implant.
Yeah. Yeah. That's something I'm really passionate about. I think in general, one of the reasons I gave this talk is there's an importance to maintenance with the environment that we create, right? As far as I understand, the OSA alert was supposed to be just a pre-op thing, but it's firing everywhere. So I think there's a lot of room to reduce alert fatigue. I agree, the MRI form, I don't think in its current state is probably something that's necessary in the way that it is, but I think we just don't have enough people looking at these things to perform the maintenance we need, unfortunately. As far as balancing it, there's more quantitative QI things you can do to look at ratios of alerts to the benefits that they yield. So ultimately, say the PAP clinic referral generates 4 more clicks in those yes buttons, right? But how many clicks on the back end does it save from the call to reschedule a patient, the GYN scheduler, all of those clicks are then saved. So that can be like a simple one-to-one comparison. That's kind of what I do up front, is if I'm like, okay, the net is positive, then I think it's reasonable to go forward, but there are more like rigorous methods you can do, which are a little beyond me, to be honest.
All right, thank you so much. Thanks everyone for coming to Grand Rounds.